My belief is graduate psychology is struggling with three simple problems. One, most people who are doing the teaching aren't really doing quality clinical work out in the real world, where they have no real relationship to long-term outcomes.
Welcome to the Reality Therapy Podcast, where the truth will set you free.
Welcome. I'm here today with Dr. Patrick Lockwood, who's a clinical psychologist, and I'm super excited for a great conversation, so welcome.
Thanks for having me.
Yeah, so let's start off. Tell me who you are and what your background is.
Sure. So I am a licensed clinical psychologist in the state of California. I have been working as a treatment center operator for about the last 8 to 10 years. So I've been working, as I jokingly call it, in Rehabistan because the rehab industry is rather messy for dozens of reasons. So I've spent most of my time working with acutely, severely mentally ill people who also tend to have a co-occurring substance use disorder, a very severe one. And so I typically do not see like private practice, low end of the therapeutic intensity spectrum people. The clinics that I've operated, been clinical director of or COO or whatever, have been more acutely, severely ill people, serious PTSD, bipolar, schizophrenia, drug addiction, etc. And so most of my background clinically, both before graduate school, during graduate school training, and after graduate school, has been fairly severely ill people. I've never really worked with the less intense side of the clinical spectrum. I'm also professor at California Lutheran University. I teach in their graduate program. I teach MFTs and future PsyDs and have been doing that for about 8 years. And I'm involved in a number of startups. I'm a consultant. I do a number of things. I'm just a busy guy.
Nice. Yeah. I definitely enjoy following you and getting your takes on things. I also reside in Rehabistan. I'm in the addiction treatment. That's my work background, and I'm getting my internship at a rehab right now. So that's
nice.
Gosh, I feel like that's such a different world than the rest of therapy. Like,
it really is.
I feel like so much of the advice that I get from professors in grad school is kind of geared towards what you might call the worried well, somebody who goes to a private practice, that just does not seem at all applicable to the type of clients that you and I see.
100%. I can only imagine. And for me, it's not even that the faculty don't understand. I think it's a question of like, what are the operating parameters that you have in a clinic in Rehabistan versus in a private practice, right? So there's all sorts of people involved, family, support system, spouses, that are almost never involved in psychotherapy in like an outpatient therapy setting or a private practice setting. So it's apples and oranges. It's like training to work in an ER versus training to be like a primary practice doctor. They're not remotely the same thing in any way, shape, or form.
One thing that I see that seems to be a recurring theme in therapy generally, certainly something I see in my program, is like a kind of the affirming model, not just with gender affirming care, but just kind of what I call like the customer's always right mentality in therapy. And that, like, again, there may be a certain type of client who just kind of needs a friend and not a lot's wrong in their life. But I feel like if someone's addicted to heroin, that is a horrible like model for how to treat somebody.
Yeah, I mean, I guess I mean, I'm in California, so it should be fairly woke out here, even though it's not. So, I mean, and maybe it's just the faculty I get to work with. I have a different experience where, all of the faculty in the PsyD department and the MFT department that I have the privilege of working with are very realistic and pragmatic people. So, we talk about affirming care when it comes to specifically, people diagnosed with gender dysphoria. But outside of that particular narrow context, I don't think I've ever heard any faculty in the 8 years I've been here say a phrase like that. So I'm sorry to hear that you're having a different experience.
Yeah, but on the flip side, it is good that there are places like where you're at where it's a very different mentality. So I think that's a good thing.
Yeah, I think there should be different perspectives. And so I'm not a fan of the idea of the customer is right, because and maybe this is controversial to some people, I don't think most people actually understand themselves. And that especially goes for people who work in the mental health care profession. So my belief is if you think the patient is correct about what they're experiencing internally, I think that you're very gullible, because most people have like multiple conflicting internal experiences throughout the day, whether they have a diagnosable condition or not. And so, even if you do have a disorder like major depressive disorder, you might experience, hopelessness or passive suicidal ideation, but that's not a static, constant experience for most people with the disorder. It's a variable experience. It's a nonlinear
Hmm.
experience. And so I would be willing to bet that people's self-reports are variable, which is why there's so much criticism in the clinical psych literature and in the psychometrics literature, the testing psych literature, about many of these self-report measures and why they're rather flimsy. And they
Hmm.
might have good test-retest reliability, but that doesn't mean that they're actually assessing the construct that they believe they're assessing, you know.
Second ago, you mentioned gender affirming care for gender dysphoria. What's your take
Mhm.
on that?
It's so funny. I just tweeted this, so we'll see if we can, dovetail these experiences. So today, I'm currently teaching the human sexuality class for the PsyD students. It's usually a summer class in my program. And it's a fun class because you get to talk about biology, psychology, and the intersection of all sorts of things. And every time I do this one entire day experience where all we do is we look at the primary source literature. So, what did the actual studies say, right? And so I go into it with a very simple framing with my students, which is where we're looking at just children and adolescents that are diagnosed with gender dysphoria. And that's it. We're not looking at the adult research because it's a different monster. And so all I do is create a structured outline on a Google document, very simple, not like very fancy, no sleight of hand prestidigitation or anything. And all I tell them to do is start adding resources, peer reviewed studies that are open access so we can read them or find them at least. And so we got through many different peer reviewed studies and the WPATH criteria for transition for kids, etc. And everyone had the exact same experience, which was they had no clue that the literature was that flimsy. And so we would look at a study, we'd look at like, this is basic scientific literacy that you're supposed to learn in graduate school, which apparently people don't apply to this particular subject, right? And so all we did, without me trying to bias the experience, I'm sure I said some things that biased it a little bit, but I tried not to, right? So I tried to let them lead the discussion in the critique. And so we'd look at the title. Where's the bias in the title, if there's any? Then we'd look at the methods section, because that's usually where a lot of bodies are buried in scientific research. So what were the study's inclusion criteria? What were the exclusion criteria? So something that people were shocked to see over and over again today, and at least 6 or 7 of the papers we reviewed, was that the kids in these studies, just, the few that I'm talking about specifically, just so we're clear, not necessarily all studies, just, I'm not trying to be dramatic about it, but like in the particular studies we were critiquing today, many of the authors wrote this very innocuous sounding, scientific sounding sentence, which is, for the exclusion criteria for these studies so they could get hormones or whatever it was, other psychiatric comorbidities that would render this treatment protocol ineffective, like serious mental illnesses, were ruled out. That's it. Which is what it's, by the way, if you look at the WPATH criteria, that's exactly what you're supposed to do, by the way. You're not supposed to put people on this regimen of hormones, etc., if they're acutely ill and undermanaged clinically in other ways. So like serious depression, schizophrenia, bipolar, personality issues, whatever it was. And so the reason that that's to me, a scandalous sentence, and the reason they picked up on it, my graduate students picked on it, is because they didn't say how they ruled that out. They didn't say, did they do a clinical interview? They didn't say they gave them a SCID, a structured diagnostic clinical interview for the DSM. They didn't say how they did it. It's just a boilerplate sentence that said, we made sure they're not that sick. So the problem there is is that, again, per the WPATH criteria, if there are other co-occurring conditions that are not well managed, starting them on these hormones and blockers is actually counter or contraindicated. It's counterintuitive for the experience because that might be a problem. Hormones plus serious depression, hormones plus serious trauma might actually worsen those co-occurring mental health conditions from an ethics perspective. So about 6 or so of the papers had a sentence like that, where it's like, well, we made sure that they didn't have other issues that weren't a problem, which is a problem to me.
Yeah. That's interesting that you bring that up. I'm not sure if you looked at the leaked WPATH files, but there were a lot of doctors giving kids hormones who were developmentally delayed, had schizophrenia, had a various number of conditions, and it doesn't seem like that part of the message got through.
Well, the thing about that is the WPATH criteria is very specific. It doesn't say you can't have a co-occurring condition. It says that it has to be sufficiently managed that the hormones will be effective for the gender dysphoria you're trying to treat. And so what that means basically is you have to be psychiatrically stable enough for the hormones to work. And so that's why that sentence that's very vague is very bothersome to me as a scientifically minded professional, because if you're telling me that you ruled them out, but you didn't say how you ruled them out, or you made sure they were psychiatrically stable otherwise, that's very confusing to me. Because in other randomized controlled trials in clinical psychology and psychiatry, they're very clear that the assessment process was X. We used a SCID, we used a CBCL, we used whatever it was to assess the experience and to make sure there were no substantially co-occurring conditions. There's no confounding variables, to use a science term. So like that was a problem, but there were like a half dozen problems that none of these young people were expecting because they just hadn't spent 8 to 10 years in the literature like I have.
So, to me, it seems like if somebody comes to you presenting with gender dysphoria and they're wanting to put in hormones in their body that are not natural to their body and maybe remove breasts, remove genitals, to me, that seems like that would be an indicator of mental illness in and of itself, regardless of the presence of any other bipolar schizophrenia. Does that make sense?
I don't know that I agree with that because first, I don't know what the statement "not natural to themselves" means. Like everybody of all sexes, both of them, they have hormones like testosterone, estrogen, etc. So like we all have the same hormones, we just have different percentages and different natural sensitivities to them based upon our sex chromosomes.
Yeah, I would be saying, so like for a female, putting like 100 times the amount of testosterone into her body, essentially.
Yeah, so that's going to have predictable consequences. And there's actually literature to that effect that says there are some predictable consequences, which is why you have to have like a moderately low dose. So like there's a paper that was done, I think, like 8 years ago that showed, and this was out of UCSF, so like it's San Francisco, but like they interviewed like 208 trans women, no trans men, sorry, female to male, trans men, and what they found was that the ones that were the most psychologically well adjusted in that sample had the lowest dose, not the highest dose, which makes a lot of, I'm not an endocrinologist, so don't sue me or anything, but like you can't go too high because it's going to have consequences. Too high testosterone for anybody is going to have consequences. So that makes sense to me.
It's kind of the same thing you see with like meatheads in the gym who are doing cycles, and they have all these consequences.
Yeah, exactly. And so I think that for a person who's like, listen, my mood is all messed up, then I'm going to tell any of my patients to go see their doctor, because regardless of your diagnosis, your hormones might be messed up. Like standard of care is, I'm not a physician, I'm a clinical psychologist, so I can't draw your blood and see if your thyroid's all messed up. Because like, as we all know, or if you're aware of the depression research, a lot of people struggling with depression have a thyroid problem, or they have a vitamin deficiency of some kind. And so, the vitamins and the thyroids aren't going to cure the depression in any way, shape, or form. But like, what if you could make it easier to do the behavioral work you're doing with major depressive disorder? If you could actually get the correct, thyroid levels, right? Like levothyroxine works really well for hypothyroidism. Again, not a physician, but like it's like saying the sky is blue. So for me, I want everyone to get their hormones checked. Whether or not you believe you have gender dysphoria or you're straight or gay or whatever your diagnosis, I bet there's a lot of low T problems and low estrogen problems in men and in women. And I would love to know if they could actually change their diet, their lifestyle. Maybe they get hormone replacement therapy if they need it. I don't know. Maybe their life would be better.
So going back to this idea of gender affirming care, specifically for
Yep.
minors,
Yep.
there's the literature on it, as you mentioned, is very flimsy. There's been big reviews coming out of Scandinavia, the CAS report in the UK. Um, what it's interesting to me because the people who kind of bought into this are people like you who have letters behind their name, who have advanced degrees. We're talking the American Medical Association, American Psychological Association. How was it that like these type of people bought into this idea that's actually like a very intense intervention with very little evidence behind it?
Well, I think what one of our problems in this conversation is it's not a new problem, right? So like we don't have great psychiatric research on adolescents for pretty much anything. Like the only, to my knowledge, I teach psychopharm, so I'm only speaking from the perspective of like a professor who teaches psychopharm. To my knowledge, psychopharm text that I have published as recently as this year is like the best psychiatric evidence we have, randomized controlled trials for anything for adolescents is for ADHD and ADHD alone. It's the only disorder that if you actually genuinely have ADHD, like genuinely have a serious hyperactivity problem or a serious inattention problem that's not something else misdiagnosed, stimulants are excellent. And they actually decrease the prevalence of substance use disorders, impulsive behavior, conduct problems, etc. So like if it's actually that condition, it's a great approach, but it's just rare. So people are overdiagnosed, whatever it is. And so we have a similar problem, which is all sorts of adolescent pathology have no quality literature. And so what people do in the absence of quality literature is rely on clinical intuition and rely on the herd, right? I don't think that's unusual in any way, shape, or form. And so if there's, let's say, some good evidence that some of these hormones kind of work in certain ways, then your clinical intuition is, well, it probably works because it seems to be working for many of the adults who do this. And so why wouldn't it work for kids, right? And so I can understand, even though I disagree with the thought process, I can understand how the APA got there because because it does show some efficacy for adults and a couple of studies for kids. And so it's not that hormones are all bad for these people. That doesn't mean they're inconsequential, in my opinion. They're very consequential. The issue is when you're operating with little to no quality data, you're not going to want to look at all of it and spend the time. You're just going to trust the authority because most people who care about this don't have the bandwidth or the interest to actually do what I did today for 2.5 hours and just tearing apart papers and talking about the pros and cons of them. Almost no one at the APA has done that or anywhere has done that because they write these like little blog kind of things that supposedly address the research, but they don't. They're very limited reviews. They're not full reviews. I think people are sold, they're sold propaganda that serves their group normativity interest, which again, that's just human behavior 101. It's not particularly pathological.
Yeah. When you kind of zoom out and look at the field of clinical psychology, therapy, just kind of generally, like what's going on in the field? What do you think is off about the field at the moment?
I think many things are off about graduate psychology. And again, I'm a very privileged person because I live in Southern California. I have excellent colleagues. I believe, in my opinion, I work in one of the best graduate programs on the planet, but I'm sure other people would disagree. But for me, it's like, I have very scientifically reasonable center lefty kind of people that I work with. And these people care in a very pragmatic way about what actually works. And the great thing is many of them are also practicing clinicians where if it's not working, it's not working, right? So it's not the purely ivory tower model, that a lot of people get. And so because of that, you can only theorize so much, but when you actually have to go talk to somebody and go see if your ideas work, things change. And so my opinion is many people that are in graduate psychology are getting ivory tower based education and not practical education. Like I know a lot of people that get a PsyD or a PhD would like to think that they're academics in the traditional sense of like a philosopher or whatever it is. And I think we are so much more like plumbers than we are like we're a trade more than we are a scientific discipline. We're a trade that uses science, which is totally valid, just like biology does that too, by the way. And so for me, my belief is graduate psychology is struggling with three simple problems. One, most people who are doing the teaching aren't really doing quality clinical work out in the real world where they have no real relationship to long-term outcomes, right? So like as much as I joke about Rehabistan, it has definitely shaped my belief that it has to work, and it has to work across different types of multiple complicated people, right? So like I will tell you, I was very theoretical in graduate school. And the moment I went to my first practicum, all that interest in the theory of things started to just disappear super rapidly.
Oh, yeah.
Because when you're sitting across from someone, you don't have the luxury of thinking intensely for 30 seconds or a minute. So to me, learning how to be good practical clinicians who have skills that generalize across populations, huge problem in graduate psychology. Problem two, no one cares about family therapy anymore. It is mind-blowing to me that the vast majority of even MFT programs, they're trying to churn out private practice therapists, and most private practice therapists want nothing to do with couples and families, which is absurd to me, especially working in Rehabistan where my whole job is not really treating the patient, but treating the entire system the person's involved in. So there's just a drastic lack for as like progressive as some people are where they care about society and systems. Almost no one talks about the family system in graduate psychology in many places. They get like lip service versions of family systems theory. It's like know some Bowen, read Leaving Home by Jay Haley, and like, you know enough, you're blessed. Do a genogram and family systems therapy. But really it's much more complicated than that. And the real life application of that almost universally missing from graduate psychology, especially at the PsyD, PhD level of things. And then I guess a final thought about what's not working well about grad psych is there's not an emphasis on scientific literacy anymore. There was. They want you to do a dissertation. I did a dissertation, etc. And like that still has to happen. But many programs, especially master's programs, unfortunately, are more like degree mills. They're much more interested in just churning out practitioners who know some skills, like a plumber. So like I'm fully on board with the plumber metaphor or analogy. But if you're not teaching these people how to critique a paper and pull apart the paper statistically, even if you think you're not a statistics person, you're not good with numbers, I promise you, you can understand what a linear regression is and where the bodies are buried in a data table that explains R, et cetera, et cetera, et cetera. And so those are the three big problems that I see that I think if we fixed even one of them, we would just get such better outcomes and fewer people would actually come to therapy, in my opinion.
So I want to touch on that like diploma mill phenomenon, because that's something I was talking to someone, Jen Hawk, the other day on the podcast. And, we're like, it just seems like they're churning out just so many new graduates for, in my case, Masters of Counseling, but I'm sure it's true for MFT and social work and all these other degrees. And it feels like I'm graduating December and getting licensed, and it feels like just as I'm going to be like officially entering the field, I'm coming into a field that's going to be completely oversaturated, where there's way more supply than demand. What can you tell me about what I'm walking into?
I can't tell you because I don't know where you currently live. And so I don't know what the market looks like there. I would tell you that generally it's like any other business. So if you're good at your job, even mediocre people have a full caseload. So if you're good at your job, then you'll be fine. And you'll have a good reputation. You'll have colleagues that like you. You'll have colleagues that don't like you, which I think is true for pretty much any profession. And so my experience is the clinicians I know and trust are the ones who are aware of seemingly deceptively simple things and take them very seriously. So like when I hear a patient is struggling with something and the first thing the therapist tells me about is their reaction and why they think they had that reaction, I'm extremely happy because they're talking about bias and countertransference. And these concepts are easy to address in a lip service kind of way. But the problem is that when clinicians take for granted their countertransference and their mistaken beliefs about what normal actually is for them specifically and how that does not generalize to the rest of the world, because our normal does not generalize to the rest of the world. Well, you and I are not remotely the same person as clinicians, even though we both look great on camera. And so what I would say is it was supposed to be a joke. It didn't land, and that's okay. It's
I loved
totally
it.
fine.
I loved it.
It's totally fine. And so the idea is, I don't believe for a second that the market can be too crowded. I think there's a lot of mediocrity in pretty much every profession. I don't think we're unique just because we go to grad school. It's a shame that grad school is not a better regulator, limiter, eliminator of less adapted people, but like it's a business. So whenever the university stops being a business, it'll be better, I'm sure. But it's a business, you know?
So I want to ask you about cognitive behavioral therapy because I feel like that's a hot topic that's always being debated in the field, and it's got like multiple angles. So your CBT people are saying this is where all the evidence is. This is the most evidence-based, form of therapy. Your psychodynamic and psychoanalytic people say it's shallow. You're not really getting the full depth of the human experience, so you're not really getting a core change in the person. And kind of your social justice perspective is that CBT is like gaslighting the client. So what do you think about CBT?
I don't know. I mean, CBT is just yet another tool. I think that my concern is who is the person that is using the CBT and how are they using it? Because let's talk about it like a thought record, right? So a classic tool, or even like Socratic questioning, is a classic tool in CBT. And so you could be a psychodynamically minded practitioner who is aware of your countertransference and the patient's transference behaviors and feelings and still do Socratic questioning and achieve something deeper than just challenging their core negative belief. And so for me, I think that the idea that CBT is the problem because it's superficial is also a very superficial narrative. I tend to not agree because I think you can be a fairly deep person and shoot for depth with people, regardless of the clinical diagnosis, and still use superficial tools. And I think back to what I said earlier about being a pragmatist, like living in Rehabistan, there's no amount of talking about your childhood that is going to get you to stop using drugs. I've been in Rehabistan for 15 years. Never once have I talked about their attachment insecurity, and that fixed it. Ever. And you're talking to a guy who grew up in the home of a psychoanalyst, basically. So like, I am not ignorant of, I'm extremely well read in everything psychoanalytic, from Freudian to ego psychology to object relations. I was a self-psychology guy for a long time because out here in LA is the hub of self-psychology. So like, I'm about as psychoanalytically minded as most people who do the work. But when you're faced with acutely ill people, all of that giving a shit about 0 to 5 goes straight out the window, because you can certainly have pathological dependency issues and oral fixations. And those are all real concepts that are somewhat interesting and useful. But like, if you can't teach people how to increase metacognition and increase delay of gratification, I don't give a shit about your childhood. I just don't. I need you to learn how to regulate right now so that if it is useful to talk about that, we get to that at some point. So I'm extremely biased because of Rehabistan, which is I'm all about understanding the deep patterns of how you see the world and my countertransference and your transference, and I'm all about it. And all these psychological games that are worth exploring are useless if you're still high, if you're still psychotic, if you're still cutting yourself. It's all fucking useless to me.
Yeah. No, I love that. 100% agree. How threatened are you, or how threatened do you think I should feel about the threat to our field by AI therapy?
I don't know. I mean, maybe, maybe. So like, I can make two arguments. So you used the phrase worried well earlier, and I'm very grateful you're the one who said it, not me. So it is my
Is
belief.
that a controversial term?
No, I don't think it's controversial. It's just I'm just known for deriding the profession. So I have a whole YouTube channel about it. So like it's just nice to have someone else doing it for me. Like I am sure that the worried well will absolutely leave therapy once these chatbots, etc., become more refined and better at moving and shaking and shifting. And I'm happy about that. Like I think the people that are mildly anxious or have struggle with milder depression, etc. And I think that Alan Francis, if you don't follow him, Alan Francis is a psychiatrist.
Is that the guy who chaired the DSM-4? Yeah.
Amazing. Very bright, very incisive, gives zero fucks. He is, I think I agree with his opinion. Let me say it this way. The mildly ill will probably use more of that and need less of us, which I think is awesome. And just so you know my bias, so it's 100% clear that it's not anyone else's opinion, it's not a scientific opinion. My bias is most people don't need therapy. I believe half to 2/3 of us should be out of a job, in my opinion. And the reason's because the vast majority of people with mild or moderate conditions probably can do a dozen other things that don't require us, that get rid of us.
That is really interesting. And I guess that leads into the next question of what do you think of the proliferation of therapy concepts into the broader culture? Because I feel like that's a big part of why so many people think like, oh, everyone should go to therapy.
Hate it. Hate it. I hate it so disgusted by it because listen, like no judgment to the people who use therapy speak who are not in our profession. And I can't even stand it when people in our profession do it because the problem is most people are not speaking in a precise way. Most people are trying to use terms to achieve social goals, which is how almost every human being who's not like autistic like me or whatever talks. The problem that I face is when we mainstream any real, not even fake pseudo therapy stuff, but like real therapy stuff, like I'm talking about countertransference. I could tell you that if that became trendy, everyone and their brother would be fucking talking about it. And it would just be the incorrect understanding of what it is because the watered down thing is the popular thing, no matter what, in any discipline, in AI and math, physics, the watered down thing is what everyone can understand and talk about. Totally. And so the problem with people using technical jargon in a popular psych way, in my opinion, is it gives people a mistaken impression about their internal life. I'd rather you have a more accurate impression of what's happening between your ears than an easy to, like, I don't want things to be easy to understand. I'm very anti easy to understand when it should actually be complicated.
So I think part of this is people reading pop psychology or watching, therapy TikTok or something because they genuinely want to understand themselves better. But I'm wondering if you see something I notice is people who weaponize therapy language. Like, I think you're a narcissist and you're gaslighting me. You see that?
Yeah. Yeah. It's like trends. Trends are going to happen. And, even the gaslighting thing has died down in the last 3 or 4 years, so like, I expect these trends to happen, and I just pray that they die quicker. You know?
So you were a man in a majority female profession.
Yep.
Why are men so much less likely to come to therapy?
I feel like there is a tweet that I responded to about this.
I think
And
Dr.
so
Perrin just tweeted about it.
he did just, yeah, he did.
Yeah.
But also, I think like a couple of weeks ago too. So just so I'm hearing you correctly, and I have the specific question correct, why do you think men are coming to therapy less?
Yeah, less than women, yeah.
Okay. I mean, how much time do you have? But like, so I think there are the broad factors and the specific factors, right? So there's the broad societal, institutional factors. So I think there are simple things that might be encouraging men not to come, including like social narratives and social media and all these alternatives, right? So like you heard me say 5 minutes ago that I think 2/3 of people don't need therapy, which would probably include men as well. And so there are people who are influencers and podcasters and even therapists who are like, you don't need therapy. Go to the gym. You don't need therapy. Like, oh, this is Wilfred Riley, I think.
Riley, yeah. He's
Yeah.
super anti-therapy.
Yeah. So he and I went back and forth about this, and I think it was a pretty good back and forth. But, like, you've got tons of people who have a platform who say, you don't need therapy, go to the gym. You don't need therapy, talk to your friends more, have more dude time. All of which I agree with, by the way. I think there's a very solid case for a great many people to just go hang out with your friends, or if you're into it, go to church, or go to a civic group, go to Kiwanis, go do something to be with people and be of service, and you'll feel better. And I agree with that in so many cases. So I think there's that influence. There's a systemic influence of like influencers and podcasters and whatever it is. I think when people talk about like the influence of graduate school, right? So, there are certain narratives. It's not like a completely institutional thing, but I think that there are subsections, there are pockets in grad psych where masculinity is seen as more bad, because when things were at like peak woke in the United States in like 2017, 16, whatever it was, there was all this talk about masculinity, privilege, women. Fine, fair enough. So I'll put that on the list of things too. I think another thing I would put on the list of things is, if I look at my experience, and I'm just going to talk only about me and nobody else, I don't give a shit about your day or your life. I am not the kind of person who is interested in a story. And so, like, do men care about stories as much as women do? And so my belief, and I don't know if this is correct, but one of my beliefs is that males on average, and maybe this is me being a stereotype or sexist guy, but like, I think men care less about people's stories and more about what they're doing. Like, the stereotype about like people, like relationships, you're married, whatever, like women want to talk about the story and what happened. They don't want you to fix it. Dudes, I'm guilty of this. I want to fix it. I have 5 solutions right now. Why are you still talking? So that's that old stereotype, that old joke about like women just want you to listen. Men want to fix it right now.
Yeah.
Like, I think that's true. I don't know if it's universal across the planet, but I think it's true. And so I think most dudes would rather fix a car and not have to listen to people talk about their childhood than, like, maybe dudes are self-selecting out for that reason too. Because like, personally, the thing I hate the most is listening to people talk. I'm an excellent diagnostician and a pretty good supervisor because I see complexity pretty straightforwardly and very quickly without much of a bias or a reaction. I don't care. I'm not very attached. And so because of that, I have different strengths, but I will never be a great therapist because I will never be interested in the story. I'm interested in the solution, right? And a lot of why people like therapy and get something out of therapy is because they're having a relationship where the story gets to unfold. Now, again, I'm very biased because of how I'm built differently, but I bet a lot of guys just don't want to sit and listen to people talk. right?
Interesting.
And so I bet that's a problem or a reason why. I bet another reason why is they're very afraid of looking at their own shit.
Hmm.
I don't think we have a society that incentivizes men to look at themselves. I think we have a society that incentivizes men to criticize themselves, either in a woke way or in a like masculine right wing way, but not actually have a real relationship with themselves.
Hmm.
And so I think there's some cultural norms there too. And then I think there's all the dozens of specific reasons for a particular individual why they might not, as a male, want to do therapy. But that's just kind of my...
That is so fascinating. And I want to dig deeper into what's going on with men, because men are dropping out of the labor force, dropping out of education, addictions on the rise, overdoses on the rise, suicides on the rise. Like the numbers are just kind of jarring for what's going on with men.
Yeah.
And I see this like subset of men that's like hyper fixated on self-improvement. Like most of my friends watch Andrew Huberman, Chris Williamson, Jordan Peterson, get your act together and make the best of yourself. But a lot of men are going in a different direction where they're just kind of giving up completely. Their life revolves around video games and watching porn and just like have no intention of just kind of like withdrawing from the world, kind of giving up. Like, what do you see going on with men generally?
Yeah, I think it varies. I mean, I have this problem because I'm in LA, which is a huge city. So I just see all different types of men, so I can't like... Clinically in Rehabistan, where I spend a lot of my day, I would say the men that I deal with there are all over the map. There's not one particular, like some of the dudes like video games because they're like 20 and they're kids. But like, I don't know. I think I see all sorts of problems. I think there's subgroups of men that I've treated or worked with where their main problem is they don't believe in themselves, right? And so that's where like the Chris Williamson, Jordan Peterson, Joe Rogan kind of cluster is great because there's an empowerment. There's like a prototypically masculine empowerment approach that I think these guys need. Like I think Jordan Peterson's correct that there's at least a subset of guys who are just desperate for encouragement because the male role models in their life suck. And my belief, honestly, is that a lot of people suck at being dads. I'm a very lucky person. I had a very good dad on average compared to like the norm of the people that I'm around, including in graduate psychology, who taught me to live according to principles and be honest about what I know and what I don't know and treat people with respect, etc. So like I count myself among a very lucky subgroup of people who had like a pretty classically traditional dad who tried to invest in me. But I think a lot of people have like latchkey experiences, like Joe Rogan talks about. Like he had no consistent male influence, so he had to go find it. And a lot of people are not lucky. They don't have that in their life. They don't have good friends. They don't have like their friend's dad who can help them out, or someone at a church, or a voice. Like I'm an Eagle Scout, so I was lucky that I was also around good male role models and scouts too, because a lot of my scoutmasters were actually like good, regular, like average guys, just average Joes who were like Russ Keller was my scoutmaster, I think, for 3 of the years I was in that troop where I grew up in Festus, Missouri. And like Russ was just a good old boy. He was just a standard, had a good, he was like a bioengineer, but he just sounded like and acted like a good old boy. He was just a regular guy, a regular dad. And because of that, that's the role model I had. Just be a regular dude who does regular dude things. So let's go fishing, let's go hunting, let's go hiking, let's go do stuff. And then like, let's be dudes. And I can imagine a lot of people don't have that because their dad's busy working himself to death, or they don't have a dad. I think that's a problem. I think another problem that's affecting men for the subset that is like isolating and self-sabotaging is, what's the best way to make money?
Get a job?
Yeah, as a guy. Like as a guy, what's the best way to make money in your opinion?
Get a job? I don't know what you're looking for.
What kind of job?
I mean, I guess if you didn't go to college, like the trades would pay very well relative to education level.
Okay, but if you're in a trade, you don't need to be busting your ass 70 hours a week. In many cases, you can still play video games. You can still watch porn, and you can do all sorts of shit if you have like a successful plumbing business because you got people working for your HVAC or whatever it is. Also, a lot of people are influenced by like social media culture. They'd like to be streamers or athletes or whatever it is. And so I think there's just dozens and dozens of more options for men than there were back in the 50s and 60s. So I think there's more variability in how men are going to turn out because there's just way more options than ever. Like, you can be a streamer and an influencer as a dude and still be a dude.
It seems like there's this crisis of meaning and purpose as well, because I feel like as difficult as it is working in Rehabistan, it's extremely packed with meaning and purpose. I get a lot of fulfillment out of what I do.
Sure.
But I think like as a man who like there's this like primal drive to go, kill a woolly mammoth or something, and you're sitting behind a desk sending emails, like there's like a disconnect there, it feels like.
Yeah, I mean, I will tell you that one of the things I hate about Rehabistan is you get to sit there all day. How awesome would it be if we could design a rehab where you actually get to go like work out and do all sorts of cool shit? That's my dream, right? But you're paid by insurance companies in particular to sit there, talk therapy, group therapy, case management, psychiatry, whatever it is. And so my problem is I think we have a generally much more sedentary society, which I think is bad for everybody, regardless of race or sex or age or whatever it is. You shouldn't fucking be sitting. It's terrible. So I think that's bad. And I also think that when no one tells you that meaning matters for decades, like I really don't like the boomers and I don't like the Gen Xers because they're very interested in profit, which is totally fine as a generation. But talking about purpose is not really trendy, except for in certain subsections like religious subsets and so on and so forth. And so I just think societally, the shift towards success at the expense of meaning is a huge problem for everybody, not just men, but maybe men in particular. Because there's nothing wrong with success. I like being successful, but I also like doing things that matter to me, which is why I'm a professor. I'm not a professor because it pays good, just so everybody understands. I'm a professor because it's awesome to help people be more scientifically skeptical and hone their skills. I get to see the next generation be smarter than me and better at their job and more aware than I was in graduate school. That's awesome.
What can you tell me about the gender wars? Because I see radical feminists hating men, I see red pill bros hating women, and it seems to be born out of this resentment that like you want to sleep with the opposite sex and it's not going according to plan. Like what is going on here?
I don't know. I don't know. I mean, like, yes, online there's all sorts of wars. I'm bisexual. Come to gay Twitter sometime. You'll see people arguing about Rihanna versus Cardi B versus Taylor. I mean, there are wars online. They call it Stan Twitter, where they are obsessed with typically a female pop artist of some kind, and they are vicious towards each other. And so what I will tell you is I think that's a normal instinct to be at war if you feel less than or not included. So I don't think that it's unusual, but like in real life, I think it's more like little pockets of very mentally ill people arguing with each other on both sides, by the way. I think there's many very mentally ill conservatives in Podcastistan who would like to be smart or famous or successful or whatever. And it's just gross and stupid to me. So I tend to not think much about the gender wars because like here in LA, I don't deal with it. I deal with like very little call out culture bullshit.
Yeah. I don't know how prevalent radical feminism actually is among women, but I feel like this kind of red pill mentality is more common among men than people want to admit. I feel like there's something lurking under the surface, and I see it from time to time, and it scares me. And like I don't know what's going on here, but like a whole mentality built around kind of pseudoscience of hating women, I guess. It just something's off here.
Yeah, I mean, I think if you have a belief system that requires you to hate people, that's fascinating to me. Because I can't imagine how that's evolutionarily useful. I can
Hmm.
understand situationally, someone tried to murder me, therefore I'm going to try to kill you back. That makes sense to me. But hating a group of people is, and maybe this is because I'm built differently or how I was raised as a Southern Baptist. I have no clue. But like, how stupid is it to hate a group of people?
Hmm.
I don't get it. I can't. I can't understand. Like, I don't hate the woke people. I don't hate the conservative retards or whatever. Like, I don't hate people. Like, some people's behavior I really dislike and I'm disgusted by, but like, those are individuals specifically who do specifically stupid things. But like, there is no trans monolith or woke monolith or feminist there's none of that. You know, Judith Butler is feminist,
Yeah.
notoriously isolates herself because she's insane. One of my interns once upon a time was in graduate school with her, and she's a nut job.
I
And
definitely
like,
believe that
but like,
after reading her.
but like, there is no monolith of feminism that surrounds her. There are people who like her ideas, and there's a very small subset of people who like her. But like, there's no person who has like some monolithic group. Like, you go survey 50 conservatives, you're going to get 50 different opinions on different things. You go survey 50 different liberals or Democrats or whatever, you're going to get 50 different opinions on different things. I guarantee you, they're not all towing some party line. Just like dudes. Dudes are various. They're
Hmm.
very, very, weird, confusing people. Dudes are not all a monolith of like, let's go kill a tiger and eat the flesh. Like, yes, we all have some instinctual, like, let's go achieve things and protect and whatever, but like, so what? Like, it's so broad and nebulous that like, how are you crafting and harnessing those instincts is about as varied as there are people,
Hmm.
you know? So I don't get hating people, groups of people in particular.
Yeah. Yeah. So, if you could wave a magic wand and fix the therapy profession, what would you do?
I think that's a really bad question to ask me.
Thank you for your honesty.
Because like, I have a more antisocial answer, which is it should be mostly regulated out of existence.
Wow. Okay. Go on.
Yeah, I mean, like, here's what I would love to see happen, but will probably never happen, mostly because it's wildly expensive. But once upon a time, to get your license in many states, including California, in order to sit for your license, you had to go do an interview. Like, it was done in hotel rooms back in the day, where you would go meet with people from, in our case, the Board of Psychology here in California, and you would do essentially a clinical interview of sorts while you're, discussing like GRE items, basically. You're discussing like test items. And so I would love to see that again. And I would love to see it by people who have done their own therapy and have proof of concept that they're not mentally very ill. And so that will never happen. But if it
So,
did, it would ruin like half of everyone who's currently licensed. They would lose their career.
so make it to where the field is just like a small group of ultra talented, highly competent, like elite therapists, basically.
Not elite. I don't like that framing. It's people who've actually got the humility to say, I'm appropriately fucked up enough to know that I should be here, but also should not be here.
Hmm. Interesting. It
I
seems like we're
also,
going. Oh, go ahead.
just real quick, I also believe that people who want to do therapy are almost universally doing it for pathological reasons they're not aware of.
Go
No
on.
offense to you or anyone
No,
else.
yeah, yeah.
So, like, you know how there's this pop psych phrase, Jung's wounded healer or
Yeah,
whatever?
yeah.
So, like, I actually believe that more literally than the pop psych version of it. So, this is just my opinion. Feel free to cancel me. It's weird for a professor in grad psych to have this opinion, but like, I believe the reason or the set of reasons, the suite of reasons that people tend to come into this profession is because they probably score on average a little higher on trait narcissism. They probably score a little higher on some other measures of pathology. And they typically have either family of origin differences or childhood stuff or attachment stuff, such that they feel a strong desire to help. Now, maybe it's just all trait conscientiousness. They're just like really thoughtful people who are super organized. I doubt that. I'm sure conscientiousness has something to do with it. But if I were to put some money on it, and this will probably be the thing that actually gets me canceled from this interview and lose my job. But like, I bet you're not coming into therapy because you're well adjusted. You're coming to therapy because there's 5 to 10 or more things that you don't have an active handle on and you don't understand fully. And because of those things, you believe that if you help people, it will feel, as you said, meaningful. And so I believe pathology drives the desire for excessive meaning. I believe if you're okay, if you're more well adjusted, so to speak, you find meaning in lots of little things. So for instance, just to name the stupidest thing, I have 2 cats and I think they're amazing and shit. I can derive all sorts of meaning, and I have like, if you have a pet that you like I had a dog as a kid, a golden retriever, and like there's meaning in those little experiences that I think is powerful, that if you're appropriately open to it, like mindfully aware of the experience you're having with the pet, it feels really good. And it's not just like I'm coping with my feelings feels really good, like the pet therapy support animal, but like you're having an active relationship with another conscious creature that is valuable. That doesn't mean that you're having a human relationship. So I'm not one of those weirdos who's like a crazy cat lady who believes like my cats are my all be all end all of my life. I just believe that there's so much meaning in everyday experiences that is missed because we're so busy thinking and feeling and paying attention internally and not being mindful in like the Buddhist sense. So because of that, very few people, especially in the profession, are actually present. They're thinking and they're judging and they're not being and experiencing. And because of that, usually, getting back to my original point here, the things that they're not aware of about their childhood, their culture, the way they were raised, their orientation, their sexual needs, their spiritual needs, their whatever it is, they're getting those needs met in therapy. And I believe that's very unwell. I'm not saying you can't get some of your needs met in your profession, because everyone does. But I believe on average, it's 5 to 10 times more for people in our profession.
It's like in a roundabout way, the client is my therapist.
Yeah, that's an oversimplification of what I'm trying to say, but yes, in the sense of like, you are doing something to get your needs met with people, which is in and of itself not necessarily pathological, to be fair, but I think it's more than most people actually understand. Like, so, people want to feel smart and special and helpful.
Let me ask you, do you believe some type of pathology drove you to become a therapist?
Absolutely.
Okay. Yeah.
Let me tell you a quick story. This is how I know, or at least this is how I know for me specifically. And I can tell you dozens of stories about interns and other people I've worked with. So I vividly recall my first year of grad school. So my first year of grad school was great because I just moved to LA after living in Missouri for all of my life. So brand new experience, fascinating, weird, confusing, because what the heck is this place compared to the Midwest and the South? And so I remember being in grad school and loving school, because school is great. Ideas, concepts, discussion, debate, whatever, all good, fun, interesting. Then year 2, first practicum. I remember vividly the experience of sitting down with someone and being bored to tears. And I started to go, oh, what is this? Because I'm fairly self-aware. I'm not like a guru or something, but I'm fairly self-aware. And so I'm like, what is this? And then I that first year practicum, still continuing to pay attention to it and figure it out, practicing skills, whatever. By year 2 of my second practicum, because I had 4 before I graduated, I was also in therapy at the time. What I realized was the reason I came to therapy is very simple. I thought that if I helped people, that life would be more meaningful. Because before I came to therapy, I believed that I had an ethical, moral duty to use my gifts, my insight, my skills to help people. Which is not weird, because a lot of people come into therapy because they're more interested in using their insight, or maybe they're on average more self-aware, or whatever it is, all of which is fine and not inherently pathological. But what I realized is that I really wanted to help people because I didn't like people feeling bad.
Mm. Their feeling bad made you uncomfortable.
No, no, no. It wasn't uncomfortable. It's illogical. There's a very simple solution to your feelings. Let me help you see how you're irrational. Like Albert
Very
Ellis.
Albert Ellis.
Yep.
Yeah.
And he's actually correct, by
Yeah.
the way.
Yeah.
But the problem is that I believe that because of my insight and my gifts and my skills and whatever, that I could help people, and that would be the thing that allowed me to have meaning in my life and all this stuff. And the truth of the matter is, it's not remotely what provides meaning in my life, right?
Interesting.
So like, what provides meaning in my life since therapy and, trying on different hats in my life in Rehabistan is mentoring people. And mentoring people is great because there's no rush or urgency when you're a clinical supervisor. It's just you talk about things, you talk about ideas. The person goes and tries them and they work or they don't work. That's it. And you follow your ethics code and everything's okay. So for me, what I realized is that I was trying to get a personal need met. And the more I paid attention to my colleagues in graduate school, the more I talked to the people I grew up who were also shrinks and clinicians. And having been a supervisor for 5 years now, the more I supervise people, the more I see that people quickly work themselves out of this desire to help people. Now, maybe I'm overgeneralizing my personal experience, but I've never been wrong about this once I've cornered someone and had just a very mindful, non-pressured conversation about, like, what is it you like about therapy? Because what is it you really like about therapy? Well, to me, it's giving people insight and allowing them to feel empowered. And it's like, do I have to do therapy to give people insight and to help people feel empowered? Or can I do a dozen other things that don't involve me trying to change my parents or my ex or whatever it is?
Wow. That was a deep take right there. And okay, so I have a final question for you, and that is, when you look at society more broadly, what is one issue that we're not talking about enough that we should be talking about more?
What is an issue? Is there a particular category of issues?
I mean, I've gotten all kinds of it, marijuana, pornography, fatherlessness, the debt crisis. I mean, answers are all across the board for this one.
I mean, all of those things. I mean, like, God, all of it sucks and it's terrible for us. Like, I guess I can't pick just one, like, what are we not talking about? Is that the way it was framed?
Yeah, yeah. What should we be talking about more?
I believe we should probably be talking about non-attachment more.
Like in the Buddhist sense?
Yes.
Okay.
Because, I spent a lot of my undergrad and grad school working through kind of a Buddhist lens. And what I've arrived at is that if everything we know about, like, evolutionary psychology, neuroscience of thinking, and, all that stuff is correct, then, like, everything we think and feel is a propaganda campaign. And so if everything we think and feel is a propaganda campaign, you wouldn't pay attention to a propaganda campaign if Hitler created it, Joseph Goebbels created it, and you wouldn't pay attention to it if the federal government created it. It's like, no one thinks a propaganda campaign is a good thing. It's got this inherently negative connotation of, like, I'm being coerced and manipulated by powerful forces. And so if that view of the mind specifically is correct, then the only antidote to that, to be sane and, appropriately boundaried with yourself and other people is non-attachment. Because if I have a thought and then it just floats away and it doesn't matter, then that's mental health, I would imagine, for most people. And so I think non-attachment's not a cure-all for anything, but I think it's a mindset that I think would benefit the vast majority of people about most topics.
Very interesting. That sounds very third wave CBT.
Well, I mean, mindfulness is all the rage in that discipline, but I came to this just because my undergrad neuroscience professor was like, by the way, do you know how this works?
Interesting. Yeah.
And it was great.
That's very interesting. I love that answer. Well, Dr. Lockwood, I enjoyed it. This was a fascinating conversation. Thank you so much for joining me. I'd love to talk to you again anytime.
Yeah, I'd love to. Yeah, anytime you want.